Good morning. Welcome to the Department of Medicine Ground Rounds. As usually, I stand up here every Thursday to tell you a little bit about people and historical figures who have changed the way we think about medicine and biology before our speaker of the day. So I want to remind you about Sir James Paget. Sir James Paget was born on this day back in 1814. You know that name. He's a British surgeon and physiologist, considered like Rudolf Virchow, one of the founders of scientific medical pathology. As a student in 1834, he was a medical student, he discovered the pathogen for trichinosis. In 1877, he described Paget's disease of the bone. And his career just kept on going to the point where we have many terms in medicine where we use the name Paget. Paget's disease of the breast, Paget's abscesses, and so forth. This guy, born on this day, 1814. The second person I want you to remember is Albert Hofmann. Albert Hofmann was born on this day in 1906, about 100 years later. Swiss pharmacologist who discovered LSD. He was working with Sandoz, and he discovered LSD in 38. But in 43, I guess working with LSD, he forgot to use his gloves that day, touched this thing, and voila. Amazing. About 20 years later, LSD becomes illegal in the United States. Okay? And the third person I want you to remember is Roger Gilman. Roger Gilman was born on this day back in 1924, and he won the Nobel Prize with Andrew Scally and Rosalind Jallow for describing and isolating tyrotropin-releasing factor and doing a radioimmunoassay. But one of the things that intrigued me is that he succeeded in isolating TRF in 1968, and it said that he isolated about 1 milligram. Think about your pituitary gland, it's very tiny. He isolated 1 milligram of this thing, and it said that he needed about 5 million sheep hypothalamic to do this. I don't know who has access to 5 million sheep, but that's what it said, okay? Now, the final person I want you to remember is Theodor Schwann, died on this day in 1882, founded modern histology, described the cell as the important unit structure of animal cells. But today is about GI. He described pepsin. I didn't know this. He described pepsin. You know him as Schwann cells, but he described pepsin. Now, I'm going to leave you, because today is about the liver, with Dr. McClain. I'm going to ask Chris to come up here in a second, but I'm going to leave you with words by Galen. Centuries ago in 200 AD, he said, "Why is the stomach surrounded by the liver? Is it in order that the liver may warm it, and it may in turn warm the food? This is indeed the very reason why it is closely clasped by the lobes of the liver as it by fingers." And today we'll learn how much we have advanced centuries later. Thank you. Chris Kruger, Division Director for GI.
Good morning. I've always enjoyed introducing Craig McClain and have introduced him many times and told you where he trained, told you that he has more than now 700 publications, more than $6 million of NIH funding each year, continuous. And that is not really what I want to say today, though. What I want to say is when I first met him in 1997 on the plane coming up from Alabama, I read his CV, and in my mind I said, he's either a saint or a crook. Nobody can do all this. And what I did is I interviewed all the faculty at UK. They didn't realize this, and I've never told Craig this. I said, "Why are you happy?" Every single one of them said, "Because of Craig McClain." And this is basically what they said. He mentors us, he teaches us, he opens the door for us like a benevolent parent. He sets up the environment for everyone to succeed. And that is why so many people have enjoyed the collaborations with Craig. So anybody, even if you're not GI or liver, if you need any advice on your career, what to do to be successful in academics, please come and talk to Dr. Craig McClain.
Thanks, Chris. I wish my parents could hear that. So if you think this is deja vu all over again, that I was here a couple weeks ago talking about liver disease, you're right. And we actually have a robust backup system in the GI section. So if one of our speakers can't make it, we actually have 4 guys in our section and 2 at UK that should be able to step up to the plate right away, but I was the only one in town. So I'm going to talk about actually one of my favorite topics, and the one that I started my research on, which is nutrition and liver disease. And I just made this particular talk as a slide set for AASLD, and I'm giving this talk next week at UK, so it's great that I can give it here. Now, Jesse mentioned Paget. I thought he was going to talk about the basketball team, so I hope everybody watched the game last night. Go Cards. So I have no disclosures. Somehow somebody always seems to think that when they have a conflict of interest thing that you score at the end. I always have 2 or 3 people that think I have a conflict of interest. There's unfortunately no approved agent for malnutrition and liver disease, so there's no conflict here. Now, this is increasingly recognized as an important topic. So this is the most recent Schiff's textbook of liver disease. So it's the Bible of liver disease. And this particular issue literally just came out 2 weeks ago. And they thinned it down because it had gotten to be 2 thick volumes and it was too heavy for anybody to carry around. So they downsized it. But the one thing they did do is they added a new chapter, and it was on malnutrition and liver disease. And Dr. Smart's in the back there, I see. So we wrote this chapter together at UofL. And but this highlights the importance and recognition of the critical factor that malnutrition plays in liver disease. So our objectives in the next 45 minutes or so are to understand the prevalence and implications of malnutrition in liver disease, how to assess malnutrition, the causes of malnutrition, and then how do we give nutrition support. So, as per Dr. Roman, we're starting out with a case. So, this is a lady with cirrhosis. She drinks about 4 to 6 drinks a day, and so that ends up being about 700 calories. She drinks 3 sugared Cokes a day. These are the big ones. So, they're each 290 calories, so that's about 900 calories. She eats a lot of fast food. She doesn't exercise. She has difficulty getting out of a chair and climbing stairs. And she lives alone in an 8,000 square foot house. Her husband died about 5 years ago. So her kids brought her into me because she was having problems with forgetfulness, having problems getting around, and we had the new diagnosis of cirrhosis. So we'll talk at the end about what we did with this patient. So first, what about the prevalence of malnutrition? Well, this is best studied in big VA alcoholic hepatitis studies that were done 30 years ago or so. Actually, UofL was a participant in these initial studies. And they showed that basically, as I'll show you on the next slide, everybody in these studies had some degree of malnutrition. But what's recently been understood is once you go on to develop cirrhosis, whether it's due to viral liver disease or NASH, why you'll also develop malnutrition. So basically, it's a common denominator in malnutrition and cirrhosis. And again, these are from these initial VA cooperative studies where whatever test you use, and what I'm highlighting here, all of our tests are unfortunately not great tests in liver disease for malnutrition because the liver disease itself can impact the test. And so whether you look at total lymphocyte count, it gets worse with severe disease, albumin goes down. Our best test at the time was the creatinine to height index. And so 100% is normal. And you can see even with mild liver disease, people had alterations in nutrition status. One of my favorite slides, so what they then did was they created a malnutrition score. And so if you're 100%, you're good, and the further down you get, the more malnourished you are. So this is a graded effect, and the degree of protein-calorie malnutrition when you were admitted correlated directly with your mortality. Now, when we talk about nutrition, we can talk about macronutrients, we can talk about micronutrients. So we'll start out with our macronutrients, protein, carbohydrate, and fat. So if we look at protein, virtually all of our patients, if they have more advanced liver disease, have sarcopenia. Very, very frequent. And you can see the muscle wasting that this patient has. The average daily protein intake of guys in the VA cooperative studies was 57 grams. Yet you need a minimum of 85 grams to stay in positive nitrogen balance. So they're not eating enough protein. And what we know, actually, Steve McClain, who was at a Nestle Protein Summit that he helped coordinate about a year ago, and we had great speakers there, protein experts from all over the world. And it was clear that you need to take in big boluses of protein a day, especially as you get older, to maintain muscle mass. So you have to eat protein 3 times a day, and our patients aren't even doing it once a day. So what about sarcopenia? It impacts all kinds of outcomes related from quality of life to encephalopathy and survival. Hyperammonemia in muscle drives the sarcopenia and alcoholic liver disease, and it does that in large part, and so this will be your board question for the fellows, by upregulating this myokine called myostatin. And it's increased in all kinds of cirrhosis. It's a member of the TGF-beta family, superfamily, and inhibits protein synthesis by impacting mTOR signaling. Steve Winters is here, so he'll know that there's also decreased hormones, anabolic hormones, in cirrhosis. And actually, they've done studies showing if you give testosterone, you can improve muscle mass. Endotoxemia also plays a role. And so here's a cartoon showing all of the factors that can impact muscle mass, with myostatin being critical. And if you look, this is from an article looking at global sarcopenia. So not just sarcopenia due to liver disease, but it could be to congestive heart failure, it could be pulmonary disease, a host of things. And if you look, inflammation, aging, endocrine, neurodegeneration, anorexia, inactivity, those are all things that our cirrhotics have. What about carbohydrate? Well, the grand rounds that I gave a couple weeks ago, I talked about fructose. Fructose is bad. Stay away from it. It's an easy thing to avoid in sugared drinks. So, simple thing to tell your patients. And this is a study that one of our postdocs did here, and really was a landmark study in fructose metabolism in fatty liver, where we fed animals either water, artificial sweetener, glucose, sucrose, or fructose, and we're just cutting open their bellies. And you can see all the visceral adipose tissue here with glucose and sucrose. In fructose, there's not as much, but the fat is in the liver instead. And the liver is the worst place to have fat. And that's shown here. So fructose drives fat into the liver, and it drives hepatic inflammation. And it causes bacterial translocation, just like alcohol. And so what Ina showed, here's the endotoxemia in the fructose-fed animals. So bacterial translocation and bacterial translocation of gut-derived products. So she fed animals a non-absorbable antibiotic, and that fixed the endotoxemia, so it's related to altered gut flora, and it helped fix the hepatic lipids, showed the importance of the gut flora in this whole process. And one of my favorite articles, fructose, it's alcohol without the buzz. And so this is the unique thing about fructose metabolism compared to glucose. is it's metabolized very much like alcohol. So it's metabolized through a CYP2E1 and so cytochrome P450 system, and it goes to an aldehyde. So alcohol goes to acetaldehyde, fructose goes to glyceraldehyde, and you get this altered gut barrier function in fructose that you don't have with glucose. And if you combine the two, fructose and alcohol, you have real problems like our patient did. So here's fructose, alcohol, and the combination in an experimental model of liver disease. So the combination really gets you. What about fat? Well, different fats do different things in different types of liver disease. So in alcoholic liver disease, it's the unsaturated N6 fat, which is a lot of that's found in corn oil that's really bad. And there are epidemiologic studies that have shown that. There are animal studies that show that. And here's the U.S. consumption of linoleic acid, which is in corn oil over a century, has gone up dramatically. On the other hand, and I think I showed this slide a couple weeks ago, it's trans fats and saturated fats that tend to be the big players in non-alcoholic steatohepatitis. And so this is from the movie Super Size Me, where Ryan Hurt, when he was here, froze the frame when the physician was looking at the patient's chart and pulled off the liver enzymes. And you can see baseline, 18 days and 21 days of supersizing in McDonald's. And that's why the guy stopped, because he was getting bad steatohepatitis. Micronutrient deficiencies are very common. So even if you're not overtly malnourished, so you look at the patient, you don't necessarily see something, why he can have problems with vitamins or minerals. So vitamin A deficiency leads to night blindness. But you have to be very careful about giving vitamin A supplementation in these patients, because it can also be hepatotoxic. They're frequently thiamine and folate deficient. The thiamine deficiency can lead to Wernicke's encephalopathy. Almost every patient with liver disease, no matter what the cause, has a low vitamin D level. If I see a normal vitamin D level in a patient with liver disease, I usually think it's a laboratory error. My favorite topic is altered zinc metabolism. We've talked about that before. These patients regularly have decreased serum zinc levels, which can impact the development of their liver disease. Something that's under-recognized, and one of the things that our patients complain the most about, is low magnesium levels, which lead to muscle cramps. So almost all of our patients complain of muscle cramps in their legs, especially at night. And if you give magnesium oxide, 400 milligrams a day, that usually helps that. And these are the classic skin lesions of zinc deficiency. These are serum zinc levels in normal controls in compensated alcoholic liver disease with hepatic encephalopathy. And they become zinc deficient because they have poor intake, poor absorption, and increased losses. Now, how do we assess nutritional status? And this is kind of a laundry list of ways of assessing nutritional status in anybody. And what we'll tell you is basically all of them have problems with liver disease. So if we look at anthropometry, if you do BMIs, the classic thing we do in clinic, the dietitians do skin folds, all those can be impacted by fluid retention. So if you're looking at weight in somebody that has 30 pounds of ascites, that's obviously going to skew your BMI. Visceral proteins, which are used in a lot of, especially epidemiologic nutritional studies, like prealbumin, retinol binding protein. They're all made in the liver. So if you have liver disease, why, that causes them to go down. So they end up being good prognostic indicators, but not good indicators of nutritional status or nutritional supplementation. Something that I like to use a lot, we use in our clinical studies, and it's dirt cheap, is hand dynamometry. So it's a functional muscle status. And so this is a hand dynamometer here, costs about $100. You can see the grip score here is 44.8. And here's from one of our clinical trials that we just did, where we're looking at grip strength here in the green and MELD score in the orange. And you can see how quickly grip strength improves with nutritional supplementation and being off alcohol. Again, something that we like a lot is bioelectric impedance, where you put a small electrical current through people, and there's mathematical formula that can tell you both fat mass, lean muscle mass, and water stores in the body. And here's the machine that we have right here. Most of our patients aren't this good looking that are on the machine, but it is a very quick, you just get on here for less than a minute, and you have a total printout of all kinds of metabolic activities that are very helpful. And you can do that serially. And all it costs is having the machine plugged in once you buy it. Something that's increasingly recognized and used in all specialties now is CT scanning at L3. So the radiologists have available to them a NIH computer package that's free. And it can give you a printout of muscle mass and give you nice pictures. So it colors the different stores. So here's a patient, and the red is muscle, the yellow is visceral adipose tissue when he's relatively well-nourished, and here when he's malnourished. And you can see in red the loss of the muscle mass, and in yellow actually more visceral adipose tissue. And so basically, you clearly can't get in the hospital without getting a CT scan. You probably can't get in the emergency room without getting a CT scan almost. And so these are available, they're stored up, and so you can go back serially and look at these. Subjective global assessment is probably one of the best things to use in our patient. And that involves looking at the patient, looking at weight loss, usual dietary intake, and some simple laboratory tests. And using a scoring system, people are either well-nourished, moderately malnourished, or severely malnourished. And you can see this patient who was severely malnourished over a 2-year period of time became well-nourished. So you can turn around. Now, some people, it's a little bit harder to tell that they're malnourished. So this guy's laying in bed, he's got his remote control, actually probably can't get out of bed. And so you can have severe sarcopenia with loss of muscle mass in markedly overweight patients. And we see this all the time. And a critical thing with muscle mass is you get old at a young age. So being old with your muscles is at about age 45. You start to lose muscle mass then. And so if you're 60 and you're cirrhotic, you have a double defect there, and you're almost guaranteed to have sarcopenia. What are some of the causes of malnutrition? Well, a host of them. And it starts out with anorexia, altered taste and smell. These people aren't eating well. They generally have poor food quality, as our patient did. She was ordering takeout food all the time, a lot of sugared pop. And then when they come into the hospital, we fast them for procedures. They have ascites, encephalopathy. So multiple reasons. And if they're alcoholics, we talk about empty calories. So again, we've said there actually is healthy drinking. So 1 drink in females, 2 drinks in males is considered healthy drinking and actually does good things for your body, especially from a cardiovascular risk point of view. Most of our alcoholics haven't slipped from 1 drink to 2 or 3 drinks. They've gone to 15, which is over 2,000 empty calories a day. So there's no protein in here. There's no vitamins or minerals in here. So that's a problem. But it's the same thing with our NASH patients. They've just switched alcohol for sugared pop. And so my favorite drink is Mountain Dew. You guys know every day, every Wednesday at the VA, I have a Mountain Dew. That's my Mountain Dew for the week. But 290 calories here. So you drink 3 of these, you've got 1,000 calories. This is what's called dew mouth. And so here's the high fructose corn syrup epidemic in the United States. Correlates perfectly with the obesity epidemic. And so one of the simplest things we can do for our patients is just tell them to cut out the sugared pop. What about nutrition support? So interest in nutrition support actually happened in the 1940s, actually with this landmark paper by Patek and co-workers in Alcoholic Cirrhotics, where he just told these guys who were eating lousy food, sometimes weren't eating at all, they were just drinking, come on into our clinical research center and you'll get 3 square meals a day. You can go on back out, just come on in and eat here. And it was revolutionary. So it was a high calorie, 3,600 calories a day, high protein, 120 to 140 grams of protein a day. And they had a markedly improved survival compared to their historical controls. And in a VA cooperative study, they looked at caloric intake in the hospital. So we had actually great dietitians assessing this and correlated voluntary caloric intake with subsequent 6-month mortality. And again, a dose-response relationship. So, and these people all had bad liver disease, so their average bilirubin was 17. But if you were eating more than 3,000 calories a day, you were almost guaranteed to live. But if you were eating less than 1,000 calories a day, you were guaranteed to die. Now, what this study didn't do was force feed these guys. And that's what you really need to do. Will taking the guys that are eating less than 1,000 calories a day, putting a feeding tube down them, increase survival. So that's what this Spanish multi-center study did, like Debray and co-workers. They randomized people either to enteral nutrition, this is an alcoholic hepatitis cirrhosis group again, or steroids. And the endpoint was survival at 30 days, basically the same. Long term, the enteral group actually did better. And this is because steroids have, for unclear reasons, infectious complications long term after you've actually been off the steroids. Maybe the most important slide I'll show. Timing makes a difference. So this is a fantastic study from Germany, from Planck and co-workers, where they showed the critical importance of late evening snacks. There's a test at the end, by the way, so remember this. Late evening snacks. So what they did is they fed people the exact same snack, either at 3 o'clock or at 9 o'clock at night, and looked at body composition over time. And you can see the guys that got the 9 o'clock snack did a fantastic job of keeping fat-free mass on. Ultimately, at 12 months, the guys that got stuff at 3 o'clock did a little bit better. But this shows the critical importance of that late-night snack, and that's because once you develop cirrhosis, you have depleted glycogen stores in the liver. And so every night you go into a starvation mode, and you're going to break down a little muscle mass. But if you have that 9 o'clock snack, you won't do that. Now, I went to nutrition support meeting at the VA. We have one every month, and I walked in, and the nurses said, "Dr. McClain, you got to cut this out." And I said, "What are you talking about?" And they said, "You're making all of our NASH patients even more obese." And so we've done an overly good job of this at the VA. So it's only guys with cirrhosis that need this. So if you just have fatty liver, all we're doing is adding another 700 calories a day and making these guys fatter. So it's only cirrhotics. What about outpatient dietary counseling and follow-up? Well, this is a study from Japan where they looked at the difference between just standard care and going to a dietitian, getting dietary counseling, looking at a 3-day food diary, and getting late evening snacks again, and in some cases, branched-chain amino acid supplementation. Made a significant difference in mortality over time. Micronutrients make a difference. So zinc can impact basically every mechanism of alcohol-induced liver injury, and actually most of these mechanisms apply to all forms of liver injury. And so we give our patients zinc supplementation regularly. We usually give them vitamin D supplementation because most of them are deficient there. Again, you have to be careful with some nutrients, though, like vitamin A, for example, or copper. Special considerations. So there's no evidence that putting a feeding tube down is going to cause GI bleeding. So Dr. Marsano is fantastic about making our patients that Jewish either eat or get a feeding tube. And so we're much better at that than basically any place around the country. Do not protein restrict for hepatic encephalopathy. So still a common misconception. And so if you protein restrict, people are just going to use their own muscle mass and break it down. So there is absolutely no data that protein restriction helps. And again, more is not always better. So you have to watch out for some things like vitamin A and hepatotoxicity. The gut microbiome plays a big role. And so this is a study actually done in Russia by one of our PhD faculty, Dr. Kirpik. So this was in a detox center, and they took everybody and randomized them to either probiotics or control therapy. And then they took the subset of people that had abnormal liver enzymes and looked to see whether the probiotic therapy caused a more rapid improvement in the liver enzymes, which it did. Now, interestingly, this is only a small subset of these guys. So the majority of them actually had normal liver enzymes, and they were drinking 750 milliliters of vodka a day on the average. So it's amazing how some people can drink a lot and not get abnormal liver enzymes. This article just came out from India on fecal transplantation in bad alcoholic hepatitis with a markedly improved survival. So it's going to stimulate a lot of interest in the future in this. What are some of the novel interventions that we're doing here at UofL? Well, I'm going to talk about 3 things briefly: a mineral, a lipid, and a probiotic. So we've talked about zinc, and we've done studies in experimental animals where if we feed our mice alcohol, their liver enzymes go up. If we give them alcohol and zinc, they're partially protected. And you can see that even better with histology. See all the fat here with alcohol, very protected with zinc. Critical factor, though, is translating stuff into humans, because some of the stuff that we do in animals actually doesn't work in humans. And so that's one of the strengths of our group, is we move from animals into the human situation through a lot of translational research. And this is work that Matt Cave's been doing in alcoholic cirrhotics. So it's a zinc supplementation versus placebo study. And the zinc supplemented patients, as predicted, their zinc levels tended to go up. Their endotoxin levels, a marker of gut permeability, improved. And the bad pro-inflammatory cytokine markedly improved. And not showing you here, their child Pew score improved and biomarkers of fibrosis improved. Lipids, we do fecal lipidomics. Fecal metabolomics sounds kind of disgusting, but one of the things that we see related to lipids is consistently a decrease in a short-chain fatty acid butyrate. And the butyrate is a critical energy source for the colonocytes. It also is a HDAC inhibitor, so it has epigenetic effects. We also see alterations in bile acids and branched-chain amino acids that I'm not going to talk about. So what we wondered was, can we take butyrate and just give it back to patients and fix their liver disease? And so we've done that in mice. And we didn't use butyrate. We used a butyrate prodrug, which is basically 3 butyrates hooked together. And so here's control animals, alcohol fed, the endotoxin levels go up, and tributrin alone or tributrin plus alcohol. So the endotoxemia, gut barrier dysfunction is fixed. Same with the ALT level. So we think this is something that's very promising and shows the importance of this fecal short-chain fatty acid in liver disease. Last thing I'll mention is a probiotic. Dr. Feng from our group has studied this extensively, and he's shown in a ton of papers different ways that this probiotic may be good besides just being bacteria in the GI tract. And in his experimental animal model, he simulated the human situation where he feeds animals alcohol for 6 weeks. They get liver disease. He then continues the alcohol for 2 more weeks, but gives the probiotic along with it. So this would be similar to what we'd be doing in our patients. And what he showed was the probiotic fixed the endotoxemia, so the LPS goes down, the hepatic TNF goes down, the neutrophil infiltration in the liver goes down, the liver enzymes get better, and the histology gets markedly better, so alcohol-fed fatty liver with the LGG, it's improved. And if you cut out the mesenteric lymph nodes or adipose tissue, after we've gavaged these animals with GFP E. coli, you can see that there's not much translocation in the ones that are fed the LGG, the probiotic, but there is in the ones that just get alcohol without the probiotic. So works at multiple different levels. And what he's shown is you don't have to give the live bacteria. You can give the junk that the bacteria grows in. So the bacteria are actually making something that's good. And so he's working on that from an intellectual property basis to make a new product. So what are our overall recommendations for our patients with liver disease? So the first thing that we want to do the minute they hit the door is check their electrolytes. And that's especially because they can have abnormalities like in potassium. They can either be low in potassium because they're on diuretics, or even worse, they can be high in potassium because they can be in renal failure and be on aldactone. Or they can be on aldactone and somebody's given them a salt substitute that has potassium in it. And that can be life-threatening. So we always talk to our patients about that. and have the dietitians also talk to them. We do early nutritional assessments, regular follow-up, high energy, and high protein. We replace vitamins and minerals as necessary, and if we need to, we do enteral feeding. And very importantly, in our overweight patients, especially in the ICU, and we see a ton of these, why we use a hypocaloric, high-protein diet. And then we send them out with their nighttime snack. So in conclusion, patients with cirrhosis are frequently malnourished. Traditional nutritional support improves nutrition and may improve outcome. Nutritional therapy attenuates many of the mechanisms for cirrhosis, including gut barrier dysfunction, and this is a frequently overlooked and simple therapy for liver disease. So we're going to go back to our patient now. So again, her husband died about 5 years ago. She's been hanging out. She's very wealthy, has a big house, but basically she's withdrawn and drinking more than she should and is really becoming almost dysfunctional. So when the kids came in, their solution, because she couldn't there's no first floor master, so she had to go upstairs, was to put an elevator in the place. So I said I didn't think that was going to work. So we negotiated. So we got rid of the sugared pop and the fast food. We compromised. She gets 1 glass of wine a night. But that's if she takes her nighttime snack. We got rid of the place in the Highlands and got her in a 1-floor condo that's got a gym. Her meals are now delivered. Because she's in this condo, she's got new friends. She meets people. She actually goes to the gym every day. And we've got her doing resistance training. So I go to the gym. I'm on the usually the recumbent bike or the elliptical. I'm not a big believer in resistance training, but actually I need to be because I'm now old. And so as you get older, you need to do some resistance training too to maintain muscle mass. So I said there's a question at the end, actually 3 of them. So the first one, which is not true concerning malnutrition and advanced liver disease? Anybody have any ideas? So I tried to hit you over the head with D, that don't protein restrict patients. So this is a critical error, and we see people going home on protein restriction, losing muscle mass. Their dietitian told them to do this. Their doctor told them to do this. What's not true about sarcopenia and alcoholic liver disease or cirrhosis in general? So it's C. So myostatin is increased. So it's a myokine that goes up. And they're actually making myostatin inhibitors to fix this. And what's not true concerning nutritional support? So I've tried to pound this into you. C, right. So it's not an early morning protein snack. It's a late night protein snack that's important. Any questions? Thank you.
Great, thank you. That was very helpful. I especially like the idea of the late night snack.
But you don't need it, Jesse.
It is to match a snack with a drink.
Yeah.
Anyway, but this was very helpful because it goes from patient care to basic science to clinical to actually changing behavior. So I very much appreciated this, and it takes all of the above to take care of these patients. One of the problems you mentioned was that often what we do in animals doesn't translate to humans. And one of the things I noticed in most of your studies is that you are creating liver disease as you're testing an intervention, which your patients are already coming in with years of liver damage. Is there a model that we're starting to work on to develop a cirrhotic model that we can test function afterwards?
Yeah, so that's what every reviewer of our grant complains about. So when they don't want to fund you, they say you've got a model problem. And so in liver disease, that's one of our big problems is we don't have a good end-stage model of liver disease that relates to the human situation. So that's why we play around with animal models, but the good thing is then going to humans, which is the ultimate model.
Good. Questions, comments?
Craig, thanks for the great talk. I've always been puzzled as what the mechanism is between the 30-year-old alcoholic hepatitis patients that I took care of at Grady Hospital that died quickly from pulmonary alcoholic hepatitis that only drank 6 beers a night versus my VA patient who says he's been drinking 6 beers a night for 20 years and he's had no problem. Is it the cytochrome P450 system that's different? Is there one thing in the liver? I know that probably plays a big role. Genetically.
Yeah, so, obviously a lot of people are studying that, but so your gut flora makes a huge difference. So that's one big thing. Genetics makes a difference. I didn't get into it here, but there are genetic polymorphisms that actually play a role in your particular specialty too. So in liver disease, there are ones that involve mainly lipid metabolism, especially one called PNPLA3. And so if you have a polymorphism in that, why your chances of getting either non-alcoholic steatohepatitis or alcoholic liver disease are dramatically increased. And Hispanics are particularly predisposed to that polymorphism, and that explains in part why they're more susceptible to liver disease. And then diet plays a role. So it's not only the alcohol that you take in, but what you're taking in with the alcohol. In our experimental animals, we cannot produce liver injury basically no matter how much alcohol we give them. It has to be with a screwed up diet on top of it. So it's a multifactorial process. Mike.
Can you comment on the protein, the type of protein in plant, animal meat, or animal base?
Right. So the animal-based protein is, quote, a higher quality protein. And so there was some early literature suggesting if you give plant-based protein, you'll have less problems with encephalopathy. Number one, it's hard to take that kind of diet in long term. And number two, the quality of the protein probably wasn't good enough. So the other thing with the protein is it's especially certain amino acids, and leucine is a critical one that stimulates muscle synthesis. So a lot of the muscle builders, if you go to the health food stores, see big jars of leucine there or branched chain amino acid supplements. Yeah. So, a lot of these studies have used Ensure, which is pretty cheap. So the critical thing isn't what it is, but that they do it. So I don't care if it's Carnation Instant Breakfast. So the fact that it's something that has some calories and protein in it is the critical factor. And basically whatever they can afford, because that calories and protein will prevent them from going into that overnight starvation mode. Yeah. And it's a big thing in the elderly, too, the sarcopenia issue.
Greg, I'll let you in a minute. I can list a bunch of things that you mentioned today, and if I was a pharmacy or an industry guy, I would plug them all into an insured type bottle with no fructose in it. Is there such a thing being developed?
Yeah.
I recognize that some of these have to be clinical tested, but there's a lot of stuff in food stores that are never tested, and yet
Right.
we have a lot of data for kids.
Yeah. So we actually want to work on a liver drink, and we're working with a company on that. So as you know, the focus of our alcohol research center is nutrition and alcohol. And there are several industries that are looking at special drinks for kids to try and keep them away from NAFL and high fructose drinks. So, yeah, there are several groups looking at this. You're absolutely right. I think it's a gold mine.
You mentioned in one slide that when you bring the patients in, you're checking electrolyte balance.
Right.
Does an imbalance alter the way that electrical impedance measurement is done?
No. So before we stop, I gave grand rounds. Like I say, seemed like just a couple of weeks ago. Jesse wasn't here, but I said, you know, we all need to recognize what a great job he's done developing grand rounds here at a time when other institutions around the country see their grand rounds failing. Very few people come. Grand rounds aren't that great. There's not much excitement. We've done a fantastic job here, and we all need to thank Dr. Roman for that.
Thank you so much. Listen, this was terrific.
Great.
I like that shake. I want that shake.
So